Hi, welcome to the NMI podcast. Today we're speaking with Harri Hemilä, and what an interesting conversation this will be. So Harri Hemilä is really an expert on vitamin C and its relationship to infections. So that's the topic that we'll be diving into. Before we get into that, I'd like to give you a background into Dr. Hemilä and his work and career. So he first studied biochemistry and received his PhD in biochemistry in 1993 and then went in to study medicine. He received an MD degree and thereafter a PhD in epidemiology in 2006. His major scientific interest has been the effects of vitamin C on the common cold and infections in general. Although he's not been involved in experimental work in this field, he's carried out a really significant number of meta-analyses that have estimated the effects of vitamin C from studies published over half a century. He's also analyzed the effects of vitamin E on infections and total mortality as the ATBC Study data set, which is in some 29,000 Finnish male smokers, and has recently carried out a meta-analysis on the treatment of zinc lozenges on the duration of common cold. And along with his research, he does clinical work as a general practitioner. Um, Importantly, to give you some idea of the scope of his contributions to research, by 2021, he'd published 155 PubMed publications, 76 focused on vitamin C, 28 on vitamin E, and 12 on zinc lozenges. And one of the reasons I really wanted to speak to Dr. Hemilä is because his work is very well written and articulate, and to me, it clearly comes from a clinician. He's picking apart the evidence, analyzing it with his clinical eyes on, and you don't see this sort of delicate analysis of data that often. So I think his work is quite unique and very relevant to us clinically. So that's what we'll be diving into. So welcome, Dr. Hemilä. It's a real privilege to have you on for an interview.
Thank you very much for this invitation to this discussion.
You're welcome. So a big question to start with is, what got you interested in vitamin C?
That was actually two television programs. First one was an interview of Linus Pauling, and he was very positive of vitamin C. He gave some study names and a number of participants and what was the effect of vitamin C and so on. That made some interest, but there are lots of TV programs of many kinds of interesting topics. So you don't study archaeology because of some program. But then there was another program which was a Swedish program about the common cold, and there was a Swedish professor of virology who had a package of vitamin C tablets, and he said that these are just junk. They don't have any effect. It was this discrepancy which led that I started to collect data and wonder who is wrong. And my current conclusion is that both of these are wrong, but in different ways. So Pauling was too optimistic, but he was fully correct with the general idea that vitamin C is not limited to scurvy.
Yeah, I mean, that's a really salient point. I mean, Pauling's ideas were incredibly progressive and also controversial for the time, I think. And that's a fascinating way to start into this, is to try and myth bust different viewpoints of this topic. And that theme really runs through your work, I think. So I wanted to discuss in terms of like unpicking who was wrong and who was right and what the actual state of the science is. You have a paper was published back in 2017 called Vitamin C and Infections. And you discuss the history of use of vitamin C in infections. And this is one thing that's very striking for me of your work, is you really go into deep history of the evolution of the science in this. Can you take the listeners on a bit of a journey on the history of research in vitamin C in infections?
When we look at the early history, related to this field. Of course, people didn't use the name vitamin C. They just knew about scurvy. That was most clearly disease of the old sailing ships. And at that time, there were comments that scurvy had increased incidence of different kinds of infections. For example, Lind, who was the major author about scurvy, he pointed this out. So the association between scurvy and infections, that goes quite far. In our current understanding, of course, this means that vitamin C has relation to infections. The Lind's book about scurvy was published in some 1700s, and the second, which I would consider most important book about scurvy, was published by pediatric Alfred Hess in the USA about 100 years ago, and he pointed out in many parts that scurvy has increased risk of pneumonia and other infections. So that is one part of that question. When vitamin C was identified in 1930s, there was lots of curiosity what kind of effects that would have. And there were lots of empirical reports that it seemed to be beneficial against pneumonia and common cold. But the literature was conflicting, so I think that it was the combination that findings were conflicting, and this didn't fit well with the concept of scurvy. I mean that when people thought that scurvy is about wound healing and gums and something like that, so it didn't fit very well with that kind of concept. So I think it is this kind of explanation why this field was forgotten.
No, that's really interesting. And at what point was it picked up again? If there were early associations with scurvy and infections in the 1700s, that early, when did research interest in the role of ascorbic acid or vitamin C, become revitalized? Was it the time of Pauling or before?
Yeah. Well, I would say that the field was quite unactive before Pauling. There were some very isolated papers which didn't have any influence, but when Pauling became interested in vitamin C and he wrote the book Vitamin C for the Common Cold, that caused that there were some 24 new randomized trials. And these found conflicting results, so that problem hasn't not disappeared.
Yeah.
But when we look at the big picture, there is very strong evidence that vitamin C has effect on the common cold. But in my view, the interpretation of the conflicts should be that we should be asking who is getting benefit and what are the doses and when was the vitamin C started and so on. So there are lots of technical and biological questions which can explain the conflicts.
Yeah, that makes a lot of sense. I think one of the challenges at the time of Pauling was there were a few doctors, including Pauling, that were looking at so-called orthomolecular type approaches or mega vitamin therapy, where they were giving large doses, and they did conduct, clinical trials and so forth. But this was very controversial in medicine, in that it attracted a lot of criticism, and there were trials that were arguably even set out to debunk or disprove or discredit this type of approach. And something you mentioned in your work is that around the mid 70s, there were some key clinical trials that were essentially used as evidence to, dismiss that relationship between vitamin C and the cold. Can you speak a little bit about that and the controversy of clinical trials that debunked Pauling's ideas?
Actually, I would start with study that was published 1972 that was by a Canadian doctor, and they in some papers they clearly described that the purpose was to show that polling was wrong, and unexpectedly they found that there was a statistically highly significant benefit from vitamin C.
Ah.
But in any case, this study didn't have I think that it is still the most interesting. It is one of the very largest studies that has been carried out, but it didn't have very great influence. But the study that has had by far the greatest influence was by Karlovsky. That was carried out at NIH, and the second author was Thomas Chalmers, who was a very influential pioneer in randomized trials. So that is the background why the study became so influential. And they found that vitamin C shortened the duration of colds. But then they had data about how people were guessing whether they got vitamin C or placebo. And when they were carrying out subgroup analysis by this guessing, they concluded that it was the guessing which made people to believe that vitamin C was beneficial. I was puzzled with this study, and in 1996 I wrote a paper in which I showed that it was just erroneous. They had excluded about half of all common cold episodes from their analysis. And they could have also asked the other way. If vitamin C is effective, it is quite obvious that some people can interpret the medicine by its effects. So, and I show that their analysis is fully wrong. When I was younger, at that time in 1996, I thought that when I showed that this study was analyzed erroneously, I could make people interested in vitamin C again, but I found with time that I was too optimistic. It's very difficult to make people interested in vitamin C.
Yeah, that's such a great point, and that leads me into a paper I really loved of yours. It was for listeners, the title of that paper is Biased Against Vitamin C in Mainstream Medicine: Examples from Trials of Vitamin C for Infection, which was published in 2022. So can you speak a little bit about the inherent bias and what your experience has been, both as a researcher looking at the history of this, but also as someone who's actively involved in this field? What are the challenges that we currently face?
Yeah, in that few years old paper, I collected my previous analysis. So in the middle of 1990s, I wrote two other papers where I described problems. There were actually three different papers in the middle of 1970s, which all concluded that vitamin C has no effect. The first one was this randomized trial, which I mentioned, and another one was a review paper by this Thomas Chalmers, who is very famous. He has died, but he was very famous, and he selected trials and took their results, and he calculated that vitamin C shortens the duration of colds by 0.1 days. He stated that it was not statistically significant, but other question is that it is so small difference that it has no relevance. When I was puzzled that the data didn't seem consistent with the data that I had been reading myself. And then I took the table and I went through all of the numbers in the table, and there were lots which were simply wrong. And when I corrected, I could calculate that based on Chalmers data, I could calculate that vitamin C shortened codes by 0.9 days, which was statistically significant. So This review has been widely cited in textbooks and reviews on common cold and vitamin C and so on. Then there was a third paper by Dykes and Meyer. This Meyer was top statistician. He was inventor of this Kaplan-Meier method, Paul Meyer, and that was published in JAMA. So when you get a paper in JAMA and there are hundreds of thousands readers, that is the way you influence medicine. And I showed several errors also in that review. So the new paper, which I published a few years ago, I summarized these earlier criticism, but there are also newer studies. For example, there was a study about vitamin C for COVID, and they stopped that trial too early. But even with the data that they had collected, I could show that there was statistically significant benefit on the rate of recovery from common cold. They had used the t-test, which was not appropriate for such kind of data where you have lots of missing information, but you can use other approaches. Then there was a vitamin C for sepsis study, which was also published in JAMA, and I showed that they didn't take into account that the effect of vitamin C depended on time. So over the 4 days, vitamin C was beneficial, but when vitamin C was stopped, then there was no further benefit. So I mean that it's quite common that people are randomizing people to vitamin C as the placebo, and then they say that this is the vitamin C group. But if vitamin C treatment is only 4 days, when people are sick much longer time, that can be simply misleading.
Yeah, yeah, that makes a lot of sense. So I'm curious then, do you think, the problems with recent research are really a continuation of that example you gave in the 70s, where they basically set out to disprove or discredit vitamin C, or is it just sloppy research, or is it inappropriate methods, or
I don't think that that most of these vitamin C and sepsis studies are with the intention of disproving vitamin C. But and I would also not use the term sloppy. I mean that I would use that term for stronger kind of poor research.
yeah,
But there is a larger vitamin C and sepsis study which simply copied this 4-day treatment. I don't know why they when the first trial was positive. So their idea was that they are just testing whether it is repeatable. But you should, of course, think a little bit, what is the treatment that you actually would like to test? And if the first trial is using 4 days, you should ask, what is the basis for the 4 days?
yeah,
For this Lovett trial, which was larger, there was on average harm from vitamin C. But in my own analysis, I showed that there was no harm during vitamin C treatment, this 4-day treatment, but the harm started just after vitamin C was discontinued.
wow,
Pharmacology, we have a term rebound effect, which means that if we are stopping some medicine, there can be, for example, if I'm stopping some blood pressure medicine, it can be that the blood pressure shoots quite far upwards and so on.
yeah, that makes a lot of sense.
So I don't think there was intentional goal to disprove vitamin C, but they didn't do the thinking that they should have been done.
Yeah, that makes sense. And I think that speaks to an inherent problem in nutritional research in general, is that, um, the methodology and approach to research needs a different kind of mindset versus, like a drug-based intervention, for example. So there are nuances to nutritional research that are often missed in study design.
Yeah, and actually one big problem in these vitamin studies in general is that if we are studying a drug, the control group is empty. It is not getting any drug. People don't get prescription drugs from food shops, but I mean that we always have the situation that the control group also gets vitamin C, and here is the problem that how large is the dose?
Yeah,
And
yeah,
in some of these common cold studies, there have even been an approach that they are giving vitamin C in small doses to the control group so that they formulate that it is testing whether the gram doses are effective.
okay,
The problem is that there are also some findings where small doses are beneficial. So the dose response is very complex. So
Mhm.
people have been taking by their own initiative some close to half a gram vitamin C in the control group. And if you find some positive benefits, it's of course clear to say that that is really interesting. But if you don't find anything, you don't know what you should conclude.
Yeah, that makes a lot of sense. So real challenges in study design, and I think, huge credit to your work to helping unpick that and have people think a bit more critically around our thinking, the approach to research. And a lot of people who are listening to this are also practicing clinical medicine and are potentially interested in understanding potential benefits, if there are any for certain subgroups of vitamin C. And I'd like to discuss one of your most recent publications. So this is vitamin C for the common cold and pneumonia. That was 2025. And I think that's the Polish Archives of Internal Medicine. Is that correct?
Yeah, yeah.
Yeah, and I thought this was quite interesting because you're unpicking some of the things you just mentioned, like who's likely to respond, why previous studies, may have shown benefit in certain cohorts, what dose might be appropriate. Do you want to share some of the key findings of this analysis and your thinking in general around who is likely to benefit from vitamin C?
Um, I said that this Anderson study from 1972 is, in my view, the most interesting. And one reason for the interest is, of course, that the overall evidence was very strong. But because the study was quite large, they were able to carry out subgroup analysis. If we are comparing different trials, they have different patients and the doses are different, and how do you define the common code and so on. You have great confusions, but in this Anderson trial, they had the same dose and same outcome definition, and then they reported subgroup differences between people who had contacts with children and those who did not, and people who had frequently colds and those who did not. And in both cases where there was statistically significant difference between these subgroups, so that people who had frequently contacts with children, they got benefit from vitamin C. But those people didn't get benefit who didn't have contact with children.
Hmm.
And those people who had frequent colds, they got clear benefit from vitamin C, but those who didn't have colds frequently, they didn't. So this has, of course, practical importance. So if one is working in a kindergarten or if one has own children and so on, it is possible that vitamin C is more beneficial. Of course, the strongest conclusion that we have here is, of course, that this should be studied again. I mean, that we shouldn't draw any final conclusions from the Anderson study, which is 50 years old. This is one difference between people. Another is that there's strong evidence that people who are carrying out heavy exercise, long distance running and skiing, they can get more benefit than kind of ordinary people.
Yeah, that makes a lot of sense. And that's come up frequently in meta-analysis of vitamin C in general, is that children are more likely to benefit and
That
and
is,
people yeah, and people engaged in heavy exercise. And I've always wondered if the relationship with children is a relationship with body weight and dose. Like are they relatively getting a higher dose versus
that,
the adult?
that is possible, but in my own Cochrane review, we couldn't conclude anything further.
Mm,
But I mean that is, there are two trials actually which found dose response up to 8 grams per day and 6 grams per day. The other one was this Karlovsky study from 1975. They found that 3 grams per day compared to 6 grams per day, the 6 grams per day was double as effective. Of course, we cannot question whether we should go to 9 or 12 or 15. Are we still getting greater benefit?
yeah.
And another was Anderson study from, I think it was 1974, where they were giving 8 grams per day on the first day and 4 grams per day on the first day, and they got double benefit from the 8 grams per day.
Hmm.
So I think it is quite a possible explanation that children relatively get higher doses, but
Yeah.
it is also possible that there are some changes because of the biology.
Yeah, of course. And these higher range doses from, I'm not as familiar as you are with Pauling's work, but what I understood is that he was advocating for big gram doses. Does
Well,
that,
was
yeah,
he Pauling put very great weight on the Ritzel study, which was from 1962, and Ritzel was using 1 gram per day.
okay.
Ritzel found a great benefit, and Pauling considered that it was the 1 gram per day, which was the dose which explained that great benefit. Of course, data was very limited when Pauling was drawing these conclusions, but my own explanation is that the great benefit is explained by the heavy stress, because these were school children in Swiss Alps.
Mm,
They were doing skiing at the winter
mm.
time. So I mean that Pauling was proposing large doses for all people, and I don't think that is justified. If we look at blood levels and white blood cell levels, that is saturated with some 100 milligrams or some less than half a gram per day. So when Pauling was proposing several grams per day, I don't think there is any benefit, any evidence, and there was no evidence. But when people are sick, for example, for common cold or other diseases, there can be benefit from several grams per day.
Okay, interesting. And and with this work, have you come across any significant safety concerns related to these higher, like 6, 7 gram doses of vitamin C? Is there
Uh, I don't see that there is any evidence that some 6 grams per day is harmful. People have been taking by their own initiative such doses, lots of people, and there are lots of trials which have used some 10 grams per day and less. But there are serious toxicities when people have been administered some 100 grams per day, and the patient had some kidney disease or something like that. So people have died, but I mean that is not a problem for an ordinary common cold patient and so on.
Yeah, that's right. And that dose is extreme as well. 100 grams is huge.
Yeah. Mostly those serious harms are explained by kidney diseases and some glucose 6-phosphate dehydrogenase disease and at very high doses and so on. So.
Yeah, that makes sense. So I've spoken a lot about the common cold. I know your work has also touched on influenza, COVID-19, pneumonia, and sepsis. It's a lot to ask, but can you give us an overview of the potential clinical benefit of vitamin C in those conditions, or is it still controversial and unknown?
Well, there's no clear good data so that I would say that this trial has shown that influenza patients get benefit from vitamin C. So I mean that this is a kind of short answer, but I can give you a longer answer also. When I first I was biochemist, and then I started to study medicine because of my interest in vitamin C. And first I wrote these comments on the old papers from the middle of 1970s. And I thought that I have said everything that I have to say about the common cold. Is there something else? And then I saw that there is pneumonia. I found 3 controlled trials where vitamin C significantly reduced the risk of pneumonia. And I wrote a meta-analysis of that, and I was able to get it published in Pediatric Infectious Diseases Journal, which is a respectable, narrow field journal. And I thought that when I showed that 3 trials and the minimum effect of vitamin C was 80%. In one trial, there was 100% difference. And over this some 30 years, I have not been able to get anyone interested. But of course, one question here is the biology, that these are very special contexts. So I mean that one study was carried out in United Kingdom during World War II. Another was influenza patients who were hospitalized, and the group which was given vitamin C got significantly less cases of pneumonia. Then there was a study with US Marines which found that there were substantial, it was planned as a common cold trial, but they also reported the cases of pneumonia, and there was significant difference. So these are all very special kinds of trials, and we should not consider that ordinary people should take vitamin C in order to decrease pneumonia risk. It is very low in the ordinary Western population. In these trials, it was about 100 times higher, the incidence of pneumonia. But of course, we can extrapolate that it might be interesting in some developing countries, but that means it should be some WHO or someone like that who should organize study to properly test it.
Yeah.
So I don't think that in Western countries one should consider preventing pneumonia, but it is another question if one is treating pneumonia patients. I think there are no similar as good trials. There is one study which was carried out in United Kingdom which found a benefit. There is one early Russian study which was methodologically poor, but I find it interesting. So it's quite easy to give some gram doses of vitamin C to pneumonia patients unless they have some kidney diseases. So I mean that there we need to be, of course, cautious. But we can do some extrapolation from these common cold trials and consider biology, and I think that it is reasonable to instruct many of these patients or their doctors to use some moderate doses of vitamin C.
Yeah, makes sense.
If one goes to very high doses, then you have the question, is it really safe and so on.
Yeah,
It,
so yeah.
it is in this context, it is safe, and there is also indirect evidence.
Yeah. No, that makes a lot of sense. You're weighing up the risk versus benefit and the biological plausibility, the clinical, likelihood that it may, be useful. In addition to pneumonia, do you have much to say about COVID-19? Do we have much research in that area?
There was lots of interest in vitamin C when the COVID was starting. And there was one paper which was referring to my other analysis, and it was claiming that vitamin C shortens intensive care treatment by over 90%.
Right.
They had misread my paper.
Yeah.
I think that my number was some 12%, I recollect, but somehow either they were cheating or just forgot what was the actual effect. So the problem was that there were lots of people who were so fanatic about vitamin C that the whole field was quite spoiled.
Yeah.
There were also lots of trials. Many of them were very hasty, and people didn't have the understanding of methodology. They just wanted to start it as rapidly as possible. So I mean that it is mostly junk, this COVID research. And now that COVID has been transformed to just one kind of common cold, I would consider myself. In my own clinical work, I have not been measuring COVID from patients last winter and the previous winter. So I understand that in hospitals it may be worthwhile because we don't want that they are in the same room two older people. One has COVID and another doesn't. But in general practice, it is one of the common cold viruses currently.
Yeah, that makes sense.
That also means that we can apply the same arguments as we are using for the other common cold.
Yeah.
Yeah.
Yeah, that makes sense. And I think like with your, extensive experience in this area, both as a researcher and a clinician, a reoccurring theme in terms of looking at the potential efficacy or benefit of this is that there are probably subsets of responders, and then there are, dose considerations and other practical considerations. For the people who are listening who are in clinical medicine, what's your view of who is most likely to benefit from vitamin C? I mean, how should we be thinking about vitamin C for the common cold or influenza in terms of using it clinically?
Well, I mentioned the Anderson trial results, so that people who have contacts with children who have frequently colds, and then we have other data. If one is physically very active, one gets more benefit from vitamin C. I think that these are the major what we know currently. Of course, if we would be able to motivate those money people to carry out larger trials, we could learn more.
Yeah.
There are also some studies which have found that men get greater benefit than women. There have been some, for example, I was helping an analysis of an Israel study with swimmers, and there was no benefit for the ladies, but there was a benefit for the males. And there was one United Kingdom study of students, and there was no benefit for ladies, and there was benefit for males. So, but one should not draw too strong conclusions from these.
Yeah.
I mean that I don't see that these differences mean that no women are getting benefit, but I think that the reasonable interpretation is that we have greater motivation to encourage males, for example, to try vitamin C.
Yeah, that makes sense. And more broadly, as a way of like closing this conversation, it feels like a lot more work needs to be done to really understand this. And
I fully agree, but the problem is that neither of two of us can influence that. As I said that when in the middle of 1990s, when I wrote those papers, I pointed out errors in those 1970 papers, and I wrote the analysis of those new vitamin C and pneumonia trials. I was optimistic that when I show the errors in the old papers and the potential benefit, but I have not been able to get anyone interested.
Yeah, I mean that's a sad way to finish this interview, but unfortunately it's one of the challenges in nutrition in general is these are non-patentable, easy access, sort of not very profitable interventions. So they do tend to get sidelined a bit in terms of research. And another theme that we've touched on is that there unfortunately has been an inherent bias against nutrient-based interventions as well. So they're big challenges, but if anyone out there is listening and has money to put in research, you need to read Harri Hemilä's work because that will help you with understanding study design, what's needed, and I really appreciate you having done this for us. So I think in particular for clinicians, we have a lot of people that are very interested in this and are looking at applying it in clinical practice. So you have had influence there, but a lot of work to be done in terms of actual research. So I think that unless you've got any closing remarks, so I just want to say thank you for taking the time. It's been a great discussion. I think as part of this, I'll signpost a number of your publications to listeners so they can dig deeper and read your work. But otherwise, really appreciate your opinion, the hard work that you've done over many decades to try and push this forward. Not without, some people listening. That's what we're here for. And, again, a huge thank you.
Thank you very much for inviting me to this discussion. I enjoyed that also.
Yeah, thank you.